This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello again, I'm Derek Stitt, and welcome to the Neurology Podcast. Today I'm joined by my friend and colleague Reece Hass of Mayo Clinic. Today we're going to chat about coughing, and so Reece is going to help us clear the air on clearing the throat, because today's focus is Reece's recent November 26th Green Journal publication entitled, What are the Central Mechanisms of Cough and Their Neurological Implications? And that is in the Basic Science in the Clinic section of the Green Journal. His co-author on this is Eduardo Benaroche, who is well known to the Green Journal in the clinical neuroscience realm. Just a little bit about Reece. He's a recent Mayo Adult Neurology Residency grad, where he was chief resident and also won our department's highest resident award for clinical excellence. Now Reece is a current clinical neurophys fellow, and we're delighted that he'll be staying on staff after training. Reece, thanks so much for joining us today.
Thanks very much for having me.
The vast majority of the time, the symptom of cough or the act of coughing outside or inside of a disease state is not usually due to a primary neurological etiology. I think we realize that. But the question of whether or not someone's cough could have a neurological basis is one that I know I've certainly seen as a consultation question from other specialties. And as your article points out, neurogenic cough is a well-recognized manifestation of some neurological syndromes. But before we get into that, I was hoping you could distill down a little bit of what the first half of your article breaks down, and that's the mechanism and neuroanatomy of the cough reflex.
Well, cough as a primary neurologic cause is not incredibly common. It does come up from time to time as a consultation question and should bring to mind a few neurologic disorders. So let's get into a quick review of the neuroanatomy of cough. Remember that cough is generally a protective reflex, kind of like pain or nausea and vomiting, and stimuli that trigger it include mostly noxious and irritative stimuli, and that's across multiple modalities such as mechanical or chemical or even thermal or osmotic stimuli. Once that given trigger is present, that information is then carried by vagal afferents, largely A delta and C type fibers, and these bipolar neurons have cell bodies that are located within nodose and jugular ganglia. Most of these afferents that trigger cough arise from the large extrapulmonary airways like the larynx or tracheobronchial tree, but there are other afferents that can also trigger cough. For example, the Arnold nerve, which arises from the external auditory meatus, and then other things like pharyngeal afferents or nasal mucosal trigeminal afferents have been shown to trigger cough as well. This information is then carried to the nucleus of the solitary tract, where neurons synapse in that caudal portion of that nucleus. The main excitatory neurotransmitters that are used are glutamate, though substance P also seems to have a role in cough production. Efferents from there then project to a network that has significant overlap with the respiratory network, and perhaps that's not unsurprising. Highlights of this network include the pre-Botzinger complex, as well as the caudal ventral respiratory group, which in particular seems to be pretty important for the cough reflex, and may even subserve the alternation of that inspiratory and expiratory cough burst pattern. Beyond this sort of basic reflex arc, there's also top-down modulation of cough, and most of that data comes from fMRI studies, which have shown that regions including the cerebellum, the insula, the anterior mid-cingulate cortex, the supplementary motor cortex, dorsal medial prefrontal cortex, and the periaqueductal gray all seem to have a role in modulating cough.
This article certainly gives a nice neuroanatomy review, as you summarize there. And I couldn't help, given that I'm a person who has an interest in the neurotoxicology of drugs of misuse, and that would include pain meds, anxiety medication, and as many of you probably know, cough and cold medications can also be misused. I found it interesting your highlighting of the overlap of the cough mechanism with that of pain, and I sort of parlayed that into a renewed understanding of the mechanism of how those medications are used to treat bothersome cough. And I was hoping you could touch on that.
Yeah, absolutely. I share your enthusiasm. It's very interesting to think about the homologies between cough and pain and what potential clinical implications the similarities might have. Unfortunately, cough hasn't garnered quite as much attention as pain, but I think there is still some things that we can extrapolate from that population when thinking about cough. In particular, there seems to be, at least in part, some shared neurobiology with pain, like similar afferent fiber types, receptors, and ion channels that contribute to both peripheral and central sensitization. When I think about sensitization, I kind of oversimplify it maybe a little bit by breaking it down into peripheral and central sensitization and then descending control or modulation. The hallmarks of peripheral sensitization include many sensitizing substances like ATP or bradykinin or nerve growth factor or other pro-inflammatory cytokines and chemokines. And this process ultimately leads to the increase in the excitability of the peripheral afferents. Also similar to chronic pain, vagal C fiber afferents express substance P and glutamate, which act on neurokinin 1 receptors or NK1 receptors and NMDA receptors, respectively. Both of these really seem to be important in sensitization, and repetitive signaling through these mechanisms leads to plastic changes within the central nervous system and ultimately to cough that can be evoked with subthreshold stimulation intensity, or even cough production with otherwise innocuous stimuli like vocalization or laughing, or even inhalation of cold or dry air. Terms such as allotossivity and hypertossivity in cough have been likened to those of allodynia and hyperalgesia in pain in this context. And like in pain, there's also descending controls, for example, from the periaqueductal gray, and these seem to have a pivotal role in modulation of cough. And I think further investigation into the roles of these modulatory systems might prove fruitful in the search for effective antitussive medications. These mechanisms of sensitization in cough may explain why there's been some success in utilizing medications such as pregabalin, gabapentin, and amitriptyline, at least in certain subsets of patients with chronic cough.
Thanks. I appreciate you going through the similarities and comparing and contrasting those things. Let's transition to canvas, which is a neurological condition that is one of the best known for having a neurogenic cough as a frequent presentation. So first, I was hoping you could remind what canvas is, and then briefly touch on the possible mechanisms your article mentions by which this concept of a spasmodic chronic neurogenic cough could be spurred by the disorder.
Cerebellar ataxia with neuropathy and vestibular areflexia syndrome, or CANVAS, is a late-onset genetic neurodegenerative disorder that's mediated by biallelic intronic repeat expansions in the RFC1 gene. The main triad includes progressive cerebellar ataxia with features of bilateral vestibular areflexia and an axonal sensory neuronopathy, but patients may also have features of dysautonomia and, relevant to this discussion, a chronic spasmodic cough that can antecede the development of other neurologic features by as much as 3 decades. Histopathologic investigation has shown evidence that supports a ganglion neuronopathy with cell loss in these structures, and it's possible that the chronic cough is related to nodose and jugular ganglia involvement. Similarly, cell loss has been described within the nucleus of the solitary tract and dorsal motor nucleus of the vagus nerve, and such dropout might lead to denervation hypersensitivity. More recently, there's also been histopathologic and genetic evidence showing synaptic dysfunction, and that may contribute to the cough in this population as well.
Your article also mentions other neurological diagnoses that may have neurogenic cough as part of their presentation. So if you could just name a few of those just so that our listeners are aware that it can be a component of those conditions, I think that would be helpful.
Yeah, although rare, when considering cough related to neurologic processes, a few things really should be considered. To start, compressive or space-occupying lesions of the pons or medulla, and in a similar manner, Chiari-1 malformations. Also, demyelinating disorders such as neuromyelitis optica can lead to cough, and those patients typically have dorsal medullary lesions. The time course can be helpful in teasing out these etiologies, and typically with most of them, there are other clues that point towards the brainstem or posterior fossa, such as nausea or vomiting, dysphagia, ataxia, or other focal neurologic findings.
Yeah, I think that's good that you emphasize that in a lot of those conditions, really cough is going to be an adjunct symptom, and there's going to be other localizing deficits and signs. So that's good that you pointed that out. But it's good to know that the cough, while present, can be neurogenic in its driver. So that's good. What about chronic cough and long COVID, which is certainly a symptom that has been reported in a good portion of patients with long COVID?
It's no surprise that cough is a prominent manifestation of the acute presentation of COVID, which is predominantly a respiratory virus. But over the years, there has been growing interest in the symptoms and pathophysiology of long COVID. The mechanisms leading to cough in this patient population are not entirely clear and remains unresolved, but it's been postulated that it may be an effect of central cough hypersensitivity or sensitization. Another possibility, which may or may not be related, is that SARS-CoV-2 virus appears to have neurotropism, including regions we've previously discussed. This may have implications in the generation of cough in this patient population.
What about iatrogenic cough that our epilepsy colleagues are probably quite familiar with, especially those who are involved with devices for the treatment of epilepsy?
I think most epileptologists would be familiar with cough as a side effect of vagus nerve stimulation. VNS received FDA approval for use in epilepsy in the 90s, and its use in other disorders has been expanded through the FDA, for example, for the treatment of treatment-resistant depression and even obesity. The exact mechanisms by which this reduces seizure frequency is not entirely known, but it probably works through the diffuse projections that the nucleus of the solitary tract has. And so cough in this patient population is probably related to just vagal afferent arm stimulation in the cough reflex, and seems to also be related to the stimulation parameters such as output current and stimulation frequency. Interestingly, though, the prevalence of cough in this population generally decreases over time, and this observed attenuation might suggest a central adaptation, though not infrequently stimulation parameters really should be examined and adjusted when there's untoward VNS side effects.
Yeah, that's an interesting concept that you bring up, giving that feedback into the nucleus of the solitary tract. It almost sounds like the cough created by the VNS in that scenario might be somewhat akin to like referred pain. So that's quite interesting. So let's wrap up with this. So for patients that develop a chronic cough that's thought to have a neurological basis, your article discusses how central sensitization likely plays a role. And you've mentioned sensitization a few times now. I was hoping you could touch on how that concept informs medications that have been tried empirically for the treatment for chronic cough of neurogenic origin, or maybe used in the future.
Central sensitization may have an important role in development of cough, as we've already discussed, and may even share significant mechanistic overlap with the central sensitization that's observed in chronic pain. Considering this as a potential mechanism, medications that target this process, such as gabapentin or pregabalin or NMDA channel blockers, have been trialed with varying success. Looking to the future, other targets such as NK1 receptor antagonists or P2X3 receptor blockers may have a role in the treatment of chronic cough as well, and seem to already have some early promise that warrants further investigation.
Wonderful. Thanks for breaking all that down, Reece. Well, that's all for today. I want to encourage everyone to go out and check out the full article. I'm Derek Stitt for the Neurology Podcast. Thanks for joining.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.